Welcome to Impact Education's Payer Talk CE program, aligning policy with practice, what providers need to know from payers in retinal disease management. I am Dr. Michael Shannon. I'm a practicing endocrinologist, and I serve as the medical director for Vintegra, a medical benefits manager. Today's program is jointly provided by Medical Education Resources Incorporated and Impact Education LLC, and is designed for 0.5 contact hours of continuing education credit. This activity is supported by an independent educational grant from Regeneron Pharmaceuticals, and we would like to thank them for their support. At the conclusion of today's program, you will be able to complete an evaluation which must be submitted to receive credit. Click Complete Evaluation in the navigation within the activity. Once you complete your evaluation, you must click Claim Credit to download your certificate or, for pharmacists, submit your credit to your CPE monitor. We're pleased to welcome Dr. Mark Barakat. He's Director of Research at Retina Macular Institute of Arizona and Medical Director of Spectra Eye Institute, with advanced training in medical and surgical retina, including a fellowship at Cleveland Clinic's Cole Eye Institute. Board certified in ophthalmology and a clinical assistant professor at the University of Arizona's College of Medicine in Phoenix. Welcome, Dr. Barakat.
Thank you so much for having me. My pleasure to be here.
So in this podcast, we'll explore both provider and payer perspectives on current strategies and persistent gaps in the prevention and treatment of vision loss due to diabetic retinopathy and diabetic macular edema, DR/DME, as well as age-related macular degeneration. We'll also highlight real-world payer best practices and implementation strategies designed to improve access, align care delivery, and ultimately drive better patient outcomes across these retinal diseases. I'd like to start by discussing the insights from a recent publication that shed light on how healthcare providers, patients, and payers view current strategies and remaining gaps in preventing and treating vision loss due to diabetic retinopathy, diabetic macular edema, and age-related macular degeneration. Dr. Barakat, as a retina specialist, where do you see the biggest breakdowns in early detection and referral for DR, DME, and AMD? And what can health plans do to differentially and differently support timely diagnosis?
Well, one of the biggest breakdowns happens before patients ever reach us. So in survey data, payers most frequently cited inadequate screening in primary care as a key barrier, while providers ranked lack of patient awareness about the need for eye exams as one of the top contributors to delayed diagnosis. Really, that aligns with what we see in practice. Patients often present with advanced disease because screening either didn't occur or follow-up didn't happen. The publication also highlighted that many patients misunderstand early symptoms or attribute vision changes to aging. From a health plan standpoint, integrating retinal screening more directly into diabetes management programs, especially through teleretinal screenings, could make a measurable difference. Evidence shows that technology-enabled screening increases follow-up rates, and embedding retinal health into chronic disease workflows would likely close some of these early gaps.
Dr. Barakat's correct on many of these barriers from the retinal specialist point of view, and some of these patients think that the loss is part of normal aging, and they fail to recognize that this could be a real disease process for which intervention can change their course. Another challenge is many eye doctors are not on the same electronic health records, so providers don't see their notes, and humbly submitted, providers often struggle to understand some of the ophthalmology notes and can't convey the seriousness of the disease to patients who fail to follow up with their eye doctors. If we don't understand what's going on, it's hard for us to convey to the patients what they may be missing and what can be changed. And finally, many patients are so terrified of the consequence of lost vision, especially losing their driver's license, which can be a devastating loss in the rural community where I practice, for them to fail to discuss symptoms or follow up. And they're scared if they mention it that they're going to lose the freedom of driving. So as payers, we often rely on utilization management tools like prior authorization and step therapy to manage high-cost therapies. Dr. Barakat, in your clinical experience, how did these requirements impact real-world treatment decisions and visual outcomes when you're sitting in front of a patient?
Frankly, that are striking. Although over 90% of prior authorizations for anti-VEGF, so anti-vascular endothelial growth factor therapy, are ultimately approved, nearly 60% of patients experience delays. I've dealt with it today, to be honest with you, with many waiting at least a week and some waiting a month or more. In retinal diseases, time matters. Even short delays after diagnosis have been associated with worse visual outcomes. Additionally, about 2/3 of commercial coverage decisions include restrictions beyond FDA labeling, and step therapy is present in a majority of plans. Look, I understand the cost considerations, especially since high-cost drugs were identified by 65% of payers as a top barrier in this survey. These administrative steps don't usually change what we treat with, they change when we can treat. Where I think we could collaborate is around reducing friction for established retina specialists. Gold carding, streamlining repeat PAs for chronic therapy, or aligning step therapy with evidence-based protocols. That will preserve appropriate oversight while minimizing treatment delays.
You bring up gold carding, and that's a great point. There are some ophthalmology providers who have proven to be great financial stewards of their patient dollars and start with a less expensive course most of the time. So on the rare condition and time when this provider asks for a more expensive drug off the bat, why are we doubting their sincerity? And why would we put somebody with proven financial stewardship through the hoops of a prior auth? For doctors and groups where we can see that they traditionally use less expensive therapy at very high rates, we have to look at ourselves as payers and ask why we're asking questions when that provider says, I need something more expensive right off the bat. And given the frequency of injections and long-term follow-up required for anti-VEGF therapy, what payer-supported strategies, whether related to benefit design, care coordination, or patient navigation, would most meaningfully improve adherence and reduce preventable vision loss when you're seeing your patients?
Well, the adherence data in the publication reinforced what we experience daily. Up to 50% of patients discontinue treatments within 2 years, and non-adherence rates in the literature range widely, from about 1/3 to nearly all patients in some cohorts. In the patient survey, the top fears were risk of losing vision and receiving injections in the eye, which, there's obviously a natural tension there. And providers ranked high copays and transportation barriers as leading contributors to missed care. This tells us adherence isn't just clinical, it's emotional, logistical, financial. There's a whole gestalt there that needs to be addressed.
So when you mention some of these barriers, one of the things as payers we can do is step forward when we know this is an issue to try to help. We have helped patients with gas cards. We have helped patients with our care navigators coordinating dial-a-lift, and some of the resources that patients, especially patients who are very proud and find it hard to accept help, these are things that patients don't know about, and often things that retina groups don't know payers do in the background. And the survey beyond this showed strong payer interest in expanding screening programs and earlier identification of at-risk patients. From your clinical perspective, running a practice and seeing patients, what does successful implementation of payer-supported screening actually look like in practice?
The data suggests this is one of the highest impact opportunities. So in the survey, payers ranked expanded access to screening, such as teleophthalmology and community-based programs, as a top system-level intervention to prevent blindness. At the same time, nearly half of payers reported that current quality measures miss key at-risk groups, particularly older adults without diabetes and patients with age-related macular degeneration. So successful implementation means embedding screening into existing diabetes or chronic care workflows rather than treating retinal care as separate. I would argue it's one and the same. Evidence cited in publication showed that patients offered teleretinal screening were 1.5 times more likely to complete an eye exam within 6 months. From a practice standpoint, when screening is integrated into primary care or endocrinology visits and referrals are automated, it significantly reduces late presentation. That's where we see real outcome improvements, fewer patients arriving with advanced vision-threatening disease. And like anything else in life, the earlier you get to something, the more likely treatments will work. And typically speaking, the better chance you have at a better outcome.
So you touch on some of the challenges within primary care screening. And I think primary care providers, and as an endocrinologist, are pretty well tuned into the need for diabetic eye screening. Many of our health systems and provider groups have quality scores and sometimes pay for performance tied into diabetic eye screening. And many EHRs have built-in reminders and care gap alerts for failed diabetic eye screening. We have alarms that go off and tell us in the office this person hasn't been seen for their eyes. And it doesn't mean that it always gets done, but it does mean that we know to look for it. This isn't true for macular degeneration, and I don't know of any similar systems for which macular degeneration and moreover PCPs recognize that this is something that needs to be addressed. PCPs see diabetic eye disease as, I'll call it in quotes, a diabetic problem and something they should watch. But I think for a lot of us, we see macular degeneration as, and I'm drawing an artificial line, an eye problem, and we don't track that necessarily as ours. And I think the loss to follow-up factor and the failure to address is much greater for AMD. The report highlighted administrative barriers, but it also did show payer openness to reducing prior authorization and step therapy requirements. And where have you seen in your market or from your colleagues streamlined utilization management make a measurable difference?
In the HCP survey, reducing prior authorization and step therapy requirements was one of the most highly selected system-level strategies to improve outcomes. And I can personally, I throw my vote behind that as well. Providers, frankly, also ranked improved insurance coverage and reduced administrative barriers as a top priority. When plans implement gold carding for high-performing retina specialists or limited repeat PAs for ongoing therapies, it reduces delays without really compromising oversight. The publication also noted that denial rates are highest when patients are initiating therapy or switching due to treatment failure, arguably the most vulnerable periods. Streamlining these points in the care pathway directly supports earlier initiation and sustained treatment, which translates, at least one would hope, to better visual outcomes.
You bring up a fair amount about the gold carding and something I've touched upon earlier. Trying to get these patients brought into therapy depends on us identifying and often trying to get them sent in earlier. I don't know how much of a factor you see for drop off in the difference. Do you see a difference between people being brought in for diabetic retinopathy and for macular degeneration, or at least a difference in how people's primary care providers have discussed the problem with them?
So, to your earlier point about a PCP looking at diabetic retinopathy as part of the spectrum of diabetes and AMD really being separate, I think that holds true. So, AMD patients tend to come to us not via their primary care physician, but usually via optometry or self-referral, or they're just having issues with their vision. And so, could the PCP play a role in earlier referral? I think absolutely. I think the American Academy of Ophthalmology recommends that patients over the age of 65 be screened once a year. And one of the many reasons to look for is AMD. Now, in terms of diabetes, you're right. There's lots of check boxes. There's lots of requirements. And so I do think that endocrinology and primary care is much better at referring that sort of thing. Ironically, once they come in to see retina, on average, macular degeneration patients are pretty motivated to keep coming back. And it's actually, the paradigm is flipped. They tend to follow up, I think, a little bit more regularly than your diabetic retinopathy patients.
I think you touch on, in terms of understanding, many of us as payers have care management teams, large teams that try to partner up with high-risk patients. And one of the challenges for the two different states is our team often knows the persons with diabetes who are in tough shape, because these are often people we're engaged with for their diabetic kidney disease or diabetic foot ulcers, and we are often not as well programmed into the needs of people with macular degeneration with whom our team may have a lot less familiarity. And it rolls in, as we look at these complex patients, to the factor of high costs, and this was identified by payers as a major barrier, but providers ranked high copays and insurance burden as the leading drivers of non-adherence. How can health plans successfully balance cost management with improving long-term adherence?
When coverage is predictable, out-of-pocket costs are manageable and processes are streamlined. We see fewer missed visits and less drop-off. Impactful strategies could include reducing patient cost sharing for high-value therapies, supporting transportation benefits. That's absolutely at least anecdotally for me, made a huge difference in some of my patients. Investing in patient navigation and minimizing repeat administrative hurdles for ongoing therapy. Again, the repeat administrative hurdles. In the survey, providers ranked reducing financial barriers and early referral as the most effective way to improve care delivery. So if you compare financial support with streamlined admin support, we'd like to see, better persistence and ultimately better visual outcomes.
I've conceded, Dr. Barakat, that I had 4 hours of ophthalmology education during Bill Clinton's presidency. It's an area necessarily I don't have a lot of familiarity, but we do have a lot of familiarity with running health plans. And I think what a lot of eye doctors don't realize is that there are these resources available at payers to help with a lot of what he described. And I'd encourage you, if you're sitting there with a member struggling, to ask for their ID card and flip it over. And there is probably a phone number on most people's health plans for either care management or nurse line or the like. And a lot of what Dr. Barakat mentioned that they as providers could use for help can be provided. So I'd encourage you when you're seeing patients who are stuck to try to ask them to flip over their ID card, because again, we don't often know about these challenges until the patient discusses them with us. But if we can learn earlier what the issues are, and if it's prompted by their eye doctors to call in, we often can do a lot more to help. So these are our perspectives. We'd like to hear from you, and I'd now like to open the discussion for Q&A from our audience.
The one I have, I think I'll take the first swing. It looks like these two are somewhat related. One of them is what care management programs have been demonstrated to improve adherence to injection schedules, and how can transportation barriers to frequent injections be mitigated through payer programs or treatment selection? Well, I'll turn the treatment selection over to Dr. Barakat in a second, but for care management, the biggest has been transportation. So we have a team of care navigators as well as nurses, but this typically goes to a care navigator to try to figure out how to get somebody there. We have done gas cards, and you have to run into a little bit of an issue that you're not to the government bribing somebody by giving them, it's called inurement, but you have to put some limits on this. The biggest one is people not understanding dial lift and not understanding how we can get them there with public transportation options. But I practice at a hospital that, yes, these places exist that are half an hour from a Target or a Walmart. And so for some of these, the dial lift also requires a large block of time. Dial lift doesn't show up like your Uber does within 2 minutes of the arrival. So it takes some planning for these individuals, but transportation has been the biggest one of connecting them. And also, we have pretty good resources in a lot of our communities with the councils on the blind and some of those as well. Rebecca, I'm not sure from your end clinically what you've ever done. And again, we've talked about this. The back of the ID card, please, you take one thing out of it, flip your patient's ID card and call up because there usually are people who are there. Rebecca?
No, I mean, to be honest, from a clinical perspective, this is something that physicians and patients struggle with. So it's good to know that there are other options out there. I deal with a lot of patients that are 2-3 hours away from the major metro. I deal with some folks that are coming from the reservation, and transportation is huge. So the we are very fortunate that we have treatments, and these treatments work very well, but they wear off like any other medicine. And so there are some patients that can go in longer intervals and shorter. And the fact of the matter is, have I changed my treatment based on transportation? I have. I have extended patients, perhaps a little bit more long than I really wanted to, because I have to deal with certain things. A lot of these folks are really leaning heavily on friends and family, and that doesn't work all the time.
I'd agree with that, and the loss of driving and the fear that we talked about during the presentation is certainly part of this. This one is definitely yours. Is when is switching between anti-VEGF agents clinically appropriate?
Ooh, you're asking a retina specialist to talk about different anti-VEGF agents. How much time do you have? When is it clinically appropriate? It's always clinically appropriate to keep it in the back of your mind. Really, for me, the metrics that I look for is how well is the anatomy, how well is the vision responding to the current treatment, and what is the frequency of the treatment. So if I am treating someone with one anti-VEGF and I'm not getting controlled, then the answer is obvious. However, you can make a solid argument for someone that's getting injections every month. If they were possibly another agent and getting every 2 month treatment, that's a quality of life question as well for the patient.
Thank you. An interesting one also, which is anyone using community pharmacists to increase patient awareness of diabetic retinopathy and age-related macular degeneration. There's some use of this in the healthcare system, but for the community pharmacies, we actually experimented with this. We have, let's say my prior role, we had a core health system, but we had areas without ambulatory pharmacy in a couple of other counties. And we looked at actually paying community pharmacists to do evaluation and management visits. I'll be honest, we were gonna probably focus with them on more of the diabetes medication adjustments. Most community pharmacists are plugged into something called MTM, for medication management, where they have quality incentives and money attached to keep people on their statins, on their diabetes meds. We were looking at using community pharmacists and paying them to do diabetes visits. And we didn't really have diabetic retinopathy built into that, probably because we didn't know if they had the ability to see the pop health management tool. Um, I practice in a hospital where the local person owns three independent pharmacies, and we do a lot of partnerships. We actually, speaking transport, use gas cards with the pharmacist has the ability to give some of the hospital foundations gas cards, I believe, and also to do some co-payment management. I don't know if we've used community pharmacists in screening for these diseases or management. Dr. Barrett, do any of your community pharmacists do anything in this space?
Not that I know of. Actually, a friend of mine, I believe in Florida, tried actually did partner with community pharmacists and with imaging, retinal imaging, to see if screening would actually improve. Met with mixed results. It's a great idea. I think the question is in the details and the execution.
You know, to the point of the trust, especially in health systems where people, I'll be said, people change over primary care doctors a lot more frequently than they used to. People trust their pharmacist. I have friends who drive 1 hour to go pick up from our pharmacist, Sunil. Has an incredible amount of trust in there. It's an interesting idea where people's providers change, but not just independent pharmacies, even some of our chain pharmacies have the same pharmacist who people trust. This one, what programs can payers implement to support better screening for high-risk populations? I talked about this a little during the prepared remarks. We're pretty good at being plugged into diabetic retinopathy. We have quality metrics to it. We have Medicare stars for this. We check on claims. We see who has not had a claim. So one of the challenges in EHR is the ophthalmology and optometry notes don't always get coded correctly. So it's interesting. We had this huge gap. We looked at who got diabetic eye exams in Epic at the health system. It was 40%. But we looked at who did we pay claims on? We paid claims on about 75% of people, meaning a huge number of people did get exams, but they did not make it into the clinician's EHR. But 25% of people did with diabetes didn't get an eye exam. So we are programmed to that. I mentioned during the talk, we don't do well with uh, macular degeneration screening. It's not a quality metric. Medicare isn't tracking us as for this. And part of it is the distinction I made, as silly as this is, practicing endocrinology, the 10 or 20 hours a week is, I think of diabetic retinopathy as my problem. I think of macular degeneration as the eye doctor's problem. I said it's not fair, but I can't read a lot of the ophthalmology notes. You get them, especially the old handwritten ones, in some sort of coding, and I would try to scan down. Like by now, I can figure out PDR, ME, but yeah, that breaker may have highly legible in Arizona. They are not always the easiest to decipher. I'd rather read readout from a pacemaker uninterpreted. Rebecca, do you have any thoughts on anyone you've seen? They would come in and I just use this emoji. But
No,
over
no, no.
time,
I
yeah,
agree. Ophthalmology lives. We live in a sea of acronyms,
yes.
and so and honestly, it goes two ways. much as you might think of macular degeneration as an eye problem, I don't really think of me communicating with the primary care or endocrinologist as my issue. I'm taking care of the eyes. I assume someone else will take care of everything else, and that's faulty thinking. I agree. Um, in terms of screening for AMD, that's really hard. And part of it is, frankly, I agree with you. We have, at least I have a bias. If you see someone in your clinic in their 70s or 80s and they're saying, boy, my vision's not so good. Well, you're in your 70s and your 80s. No offense, but that may come with it. So I know the American Academy of Ophthalmology recommends a yearly eye exam every over the age of 65, and that's just because of the frequency of things going on. One thing that it just occurred to me right now is very, very simple. It doesn't capture nearly as the specifics that you want, but I'm shocked how many people never cover one eye and cover the other. I understand that your vision may not be the greatest, but if there's a large degree of asymmetry, you may want to consider seeing someone. And that's easy to do. That takes like 5 seconds.
Berga touched upon sort of what's normal in their 70s. Prior to my endocrine career, I did a geriatrics fellowship and worked as a geriatrics PCP. And the concept of normal versus common is something patients get lost in. It is common. So people, incontinence, loss of vision, certain functions that they will say, well, I thought it was normal aging. And that can be common, but doesn't necessarily mean it's normal. Some things are common as you age, spoken as the person with the readers attached to everywhere he goes. But trying to distinguish these patients, losing your vision may be common, but it does not necessarily mean it's normal and can't be treated.
Correct.
Is it easy to obtain prior authorization? I'm not chuckling at the questions. I fear I'm chuckling at how I would answer it. Did Barakat, you actually obtain it? Would you like to take a swing at that?
Um, is it easy? It depends. Yes, it's easy, but is it easy in the time frame that you would like to get it done? That's the key. Do I have patients come back regularly that come back in a week or possibly two just to make sure? Now, it may not take a week or two, but I'm building in a little bit of extra budget because I don't want to have the patient come back and, well, you know what, we still haven't gotten there yet. And I'm not saying necessarily um, that could also be on the physician side, right? How much staff do you have? How much time do you have to run the prior auth on everybody that you see, especially with the higher volumes of treatments that we do? So I think it's a real burden. And I hope as it becomes more automated, it might become easier.
I'd like to conclude the podcast and also thank you for the comments, Dr. Barakat. I have at best a skeletal knowledge of ophthalmology, and I appreciate you being able to add that. Dr. Barakat would probably say a skeletal knowledge of what goes on behind the payer box. Uh, fair enough.
Less than.
So I'd like to thank Regeneron for their support of this activity. To claim credit, please click the complete evaluation link in the activity. Once the evaluation is complete and submitted, you can select the type of credit that you require, and you have to claim your credit to get your certificate or for pharmacist to submit to the CPE monitor. And if you have technical issues, you can email Impact Education at info@impactedu, IMPACTEDU.net.